Good morning, everybody. Um, Today, we will be talking about surfactant therapy. So let's start with the milestones of neonatology as far as the surfactant is concerned. And we can't forget our dear Avery, who in 1959 started talking about surface properties in relation to the atelectasis and the hyaline membrane disease. And then in 1972, Robertson, he looked into histological appearances of the lung from the saline-treated controlled fetuses and surfactant-treated fetuses. And then in 1980, Fujiwara, he started artificial surfactant therapy in the hyaline membrane disease. So when you look into the lung growth, we can well know that our babies who are going to be born premature will be surfactant deficient because the surfactant starts preparing after 25 weeks and it's quite minimum then, and it continues to be produced even beyond 38 weeks. So that's why we also see babies who are borderline term between 36 to 38 weeks, sometimes having surfactant deficiency. And the babies whom we are seeing now, 22 to 24 weeks, are not having surfactant at all. So that's the importance of giving surfactant later on, though we know that when we are giving the moms steroids antenatally, it's helping the surfactant production much earlier on. But still, when the babies are born with a surfactant deficiency, what we can see that the opening pressure is too high, around 25. And when we are increasing the pressure beyond, it's producing a very less change in the volume. When we give surfactant to these babies, the opening pressure comes down and a little change in the pressure brings a huge change in the volume. So that's the beauty of surfactant. Having said that, if we look at the article and evidences and the Cochrane, the benefits of surfactant are many. They decrease the incidence and severity of the RDS. They increase the survival from the RDS, decrease the need of giving oxygen to these babies, the need of ventilator support, reduces the pneumothorax and PIE, and severity and incidence of BPD is decreased as well. However, the other non-pulmonary complications of the new preterm babies, like PDA, IVH, and neck, they do not have a direct effect. Now, looking at the composition of a human surfactant, basically there is a phospholipids with various fractions, and then there is a protein which has apoproteins of SPA, SPB, SPD, and SPC. D is for innate immunity, and B is for adsorption, and C is for spreading of the phospholipids. So though it is small in amount, it does have a real importance. Then when we look at the natural surfactants which are available not from the human beings but from the bovine and the porcine, there are different kinds: surfactants, Surventa, Curosurf, Infasurf, and Bless. And they are actually extracted in a different ways, like they might be a bovine lung mince or they may be a bovine lung lavage. And then there is a porcine lung mince. So they have DPPC, PG, SPB, and SPC, but the amount is different in the different surfactants. And if we look at that, then if you compare Curosurf from any of the other natural surfactants, we know that in its content of DPPC is quite high, and it is around 76 milligram of phospholipid per ml in comparison to Surventa, which has only 25 milligram of phospholipid per ml. And hence, if we give 4 ml per kg of Surventa, it gives only 100 mg per kg of phospholipid. Whereas if we give 1.5 ml per kg of porcine Curosurf, it gives 100. And if we double it, 2.5 ml, it gives 200. And that's the important difference between these surfactants. Now, when we are giving a natural surfactants, we are happy because we are giving SPB and SPC, and they have a faster onset than the first generation synthetic. However, always there is a risk whenever you're giving an animal-derived surfactant of transmitting any kind of infectious agents, a risk of immunogenicity, a risk of inconsistency of manufacturing lots, and then there are ethnic, religious, cultural concerns like porcine in this part of the world. When Muslims, they have an issue on the porcine, and the Hindus might have an issue with the bovine one. So all these we have to see, and that's why we go for synthetic ones. The synthetic, what we have is exosurf and humectant, which doesn't have any protein. So they have only phospholipids. So why we keep on requiring a newer and newer molecules? Because we are looking for a better efficacy, a better effect in comparison to the current ones. And there's a concern regarding exposure to the other animal proteins. There is a less concentration of SPB in a natural, currently available surfactants, and we are looking for a lower cost as well. So what are these modified synthetic surfactants? There are two, leucinactant and SPCS, surfaxin and venticute. So these both have a protein in them. So there is chemically synthesized peptide combined with phospholipids, and there is a recombinant SPC combined with phospholipids. So this leucinactant is approved by FDA in 2012, and there were two trials. One was a STAR trial, which was stopped early due to the slow recruitment, and SELECT trial showed that leucinactant was equally efficacious to the other surfactants. So the phospholipid content in the natural surfactants also vary. As I said, in PureSurf, it is the maximum. So now this is what we know. But what does the evidence say? Which one is better? Natural versus synthetic, porcine versus bovine, and which dose is better? 100 milligram per kg versus 200 milligram per kg. Let's look at the evidence and find the answer. So are there any important clinical differences among surfactants? That was a question raised by Sena et al. In 2007, and they said it is just a hype and there is hardly any difference or a very small difference if you're using a natural or a synthetic. But that's not right. And the other studies had shown that the rapid onset action with the natural surfactant allows the ventilator settings and FiO2 to come down quickly, and there is a less pneumothorax and a trend towards less mortality. That was by Cochrane in 2001, but we have moved forward, and there are other studies which came and looked into natural surfactant versus control in a prophylaxis trial and a treatment trial. Both showed less pneumothorax in natural, less mortality, and less PPD or death. And then there came another Cochrane in 2015, which had a huge number of studies, and they also found that mortality was less. There was no difference in PPD. There was no difference in CLD, and the pneumothorax was less. Also, the neck IVH and grade 3 and 4 IVH were less. So hence, we can say with confidence that natural till now, whatever we have available synthetic comparing to that is better as far as requirement for ventilator support is concerned, pneumothorax is concerned, and death is concerned. So natural is a desirable choice. But we also should know that there are other factors which will be having a effect on the outcome. So what was the dose which we used? What was the timing when we used? Did we use a multiple dose? And what was the mode of surfactant application? And what was the surfactant preparations? Other than that, there is a pre and the postnatal factors which also play a role. So now let's talk on initial dose, so 100 versus 200. All the studies of the PureSurf versus Surventa, where when they looked into the mortality and the other effects, they found that major effect was when we're using Curosurf 200 mg per kg. So the higher dose made a difference. And deaths and even need of redosing was better if we were using higher dose of Curosurf as compared to Baractint. And then there was another study which looked into the same, and they also found that death or oxygen requirement at 36 weeks was less if we used more than 100 mg per kg of porcine as compared to the Surfactant. And also the mortality prior to discharge was less if we are using a higher dose. It did not have any effect on CLD or oxygen dependency at 36 weeks of postmenstrual age, irrespective of the dose being used. And then what about the cost? Because we all say that Curosurf is costlier, but then the hospital stay was less when the Curosurf was being used, and that's would say that will reduce the cost overall. After all these studies, the latest study in 2019, which was a systematic review and meta-analysis, it showed a different picture from the Cochrane review. So what it did show that mortality was not much different irrespective of the dose. However, BPD and mortality together was less if you use higher dose or even when you use a lower dose. BPD itself was less in both. Redosing was less in both lower and higher dose. Air leaks were less both in higher and lower dose. Lung hemorrhage was less in both higher and lower dose. The effect was more in the higher dose, but it was also effective in the lower dose. So these were meta-analysis out of 16 articles in the review and 14 in the meta-analysis. 1,491 neonates were taken, and they found that 200 mg per kg of Baractint was much better to reduce BPD alone, BPD or mortality, retreatment, air leaks, and lung hemorrhage. And the effect was in the retreatment was more when the gestation was less. So if you compare from Cochrane 2015 to this 2019 work, there's a big difference. Mortality was quite less in the Cochrane, but here it was only showing the trend. There was no difference in BPD, air leak, lung hemorrhage, or BPD or mortality combined and retreatment in the Cochrane. All these were showing a very much favorable response. And the confounders were not seen in the Cochrane, like prenatal steroids and the gestational age. This meta-analysis did look into the confounders, and they did not find any significance of those. So this is important. And then my friend Sushma Namia and group and Jiva Sankar, they looked into goat lung surfactant, and they did not find any difference in the primary outcome of death or BPD. However, they found it was less efficacious than Baractint for the treatment of RDS in preterm infants. So this is at the moment we cannot start giving goat lung surfactant. Now another question is, when is the best time to give the surfactant administration? So either we can use as prevention or you can as treatment. In prevention you mean prophylaxis, that would be pre-ventilation and the post-ventilation less than 10 minutes or more. And then the early rescue, which means less than 2 hours, and late rescue means 6 hours or beyond. So if you see, initially it was seen that if you are giving at birth or at 30 minutes when it was compared, the lung volume was much more when you gave early, especially if you give a higher dose. Nowadays, because we are giving a CPAP early on, the role of surfactant has become lesser and lesser. So I say that CPAP is another surfactant. So if you give CPAP for RDS early on, or that means the soon when you saw the baby has distress, or late when the oxygen therapy has failed, then we have seen that if you give early CPAP, it reduces the need of mechanical ventilation, reduces the duration of oxygen. So it is a standard of care. And as I said, I would say it is like a new surfactant molecule. And lots of evidence and studies have proven that if you start CPAP in the delivery room, you will have babies fewer on ventilation, less BPD, less use of surfactant. And we have main 3 trials, support 1 and one trial which looked into this, early CPAP versus delivery room surfactant. And the point trial had shown that if you give CPAP early on, half of the babies were never ventilated, surfactant use was halved, and death was less at 28 days and 36 weeks. Pneumothorax was more in this group because they were using a higher PEEP in the CPAP. There was no difference in mortality or other morbidities. Then came the support trial, which also gave CPAP, and comparing to surfactant group, definitely the use of surfactant was much less, but 67% versus 99. Air leaks were less, and duration of mechanical ventilation was less. So another study when comparing prophylactic versus early selective surfactant combined with CPAP showed that in a spontaneously breathing preterm newborns who are treated with CPAP, prophylactic surfactant given within 30 minutes of birth is not superior to early selective surfactant in terms of requirement of the mechanical ventilation in the first 5 days of life. And hence, another multicentric trial was done. And what did it show? That surfactant therapy in nasal CPAP, one dose of surfactant, 200 milligram per kg in preterms with moderate RDS on CPAP, reduce the need of subsequent mechanical ventilation. So when we combine the support and the WARN trial and look at the prophylactic surfactant versus early selective surfactant, it's surely said that if you give prophylactic surfactant, there is an increased risk of death and BPD. So there is a less risk of death and BPD when using early surfactant, when you are stabilize this baby on CPAP, giving them selectively, and hence decreasing the intubations as compared to prophylactic surfactant. So what we learned, that definitely we are not going to give a prophylactic surfactant, we will be going for a selective surfactant. But when to give? So if you give an early surfactant, if you really have to give, that is within 2 hours, as compared to the late surfactant, then the mortality is less, air leak is less, CLD is less, CLD or death is less. So if you have to give, you should give early. So in Neonatology 2011, Newborn study group said that give surfactant when your FiO2 requirement is more than 40% and give them within 2 hours. European Consensus Guideline 2019 says that you give surfactant if you have a baby on CPAP more than 6 and FiO2 requirement more than 30%. Should we give multiple surfactant doses? We might need a multiple doses. Why? Because adequate dose used is surfactant pool of 5 milligram per kg and therapeutic dose of 100 milligram per kg is used. But what is happening is surfactant is continuously recycled. So there is an endogenous surfactant and an exogenous surfactant. So that means that we don't really need for all the babies. However, the babies who have lung injuries, who have proteins in the edema fluid, which will inhibit the surfactant function, surfactant might get inhibited by infective processes, blood or meconium. These are the babies which may be requiring redosing. And also if you're not using a proper FRC, which helps in production of endogenous surfactant and recycling of exogenous surfactant, then also these babies might require a multiple dose. So a study was done, a multicentric study was done to see the single dose versus multiple dose, and they found that multiple dose had less mortality, 13% versus 21%, and less pneumothorax, 9% versus 18%. And the ventilator days were decreased by 2 to 4 days in the multiple dose group. So these multiple doses are helping to reduce the pneumothorax, to reduce the neonatal mortality. It improves the oxygenation and reduces the ventilation, but you should know whom to give the multiple dose. So if our babies are not getting better and your oxygenation is not coming down after 6 hours of your surfactant, you need to give a multiple dose, 6 to 12 hours. Now, how to administer surfactant? Should you do Ensure? Should you use Lisa Mist? And when should you use Salsa, that is element? So if you look at INSURE, the results of the meta-analysis of 5 trials showed that if you do INSURE, there is definitely a reduced need of mechanical ventilation, reduced air leaks, reduced BPD. However, surfactant use was more. So INSURE is intubating, giving surfactant, and extubating. So definitely it's good. And it's better if you're using it on an early surfactant than the late. Then there was an open label randomized trial which looked into INSURE versus LISA. And LISA is when you're giving you're not intubating the babies with the endotracheal tube, you're using a small catheter, which you can use a LISA catheter, and then giving a surfactant without pushing too much of pressure to the lungs, and hence causing less lung damage. So definitely it should be, and then you're not ventilating the babies. So if you're comparing this from INSURE, you found that mechanical ventilation at 3 days was much less with LISA, and any kind of mechanical ventilation was much less with LISA. So we are going more and more towards less invasive things. And then another study, it was like a meta-analysis which looked into LISA versus intubation for surfactant delivery, that is INSURE. And they looked into effect on death and PPD. And they found that definitely with the LISA, there were less deaths and PPD. However, I would say that you should be trained to giving LISA. There might be spillage of the surfactant while you are giving LISA. There may be a failure while you are doing LISA and you might have to intubate. Also, there are apneas and bradycardias seen with LISA. So we should know that it is not totally safe. One should be doing quite good of practice and to do that. And LISA catheter is very nice way to deliver this LISA. And we are using the LISA catheter in our unit, and we have seen a very good results. And then this same Cochrane showed that there was a combined effect on BPD was much better when you're using LISA. So these findings were limited by overall, all these studies were low quality of evidence and lack of robustness in a higher quality trials, but it does show good results. And then another high quality trials, when they were included for looking at the mortality, it was seen that there was no difference in the mortality and there was no difference in the BPD. So if you are not intubating the babies and you're giving surfactant versus when you're intubating the babies and giving surfactant, then another study which showed that survival without BPD was actually similar in the control and the LISA group. So it did not improve the survival, but was associated with increased survival without major complications. Like pneumothorax was less with LISA and IVH was less with LISA. So though BPD was not less, but the pneumothorax and the IVH was less. So this is because we are giving easily, we are not pumping, we are not increasing the pressure, and that might be the reason for it. So I would say that we have enough evidence that we can give LISA to our babies. Then we want to go more and more non-invasive. So we have found another way, giving a nebulized surfactant to reduce the severity of RDS. There was a blinded parallel randomized controlled trial by Stephen et al. And infants were randomized to bubble CPAP or a bubble CPAP and nebulized surfactant. The customized vibrating membrane nebulizer was used. And they found that early postnatal nebulized surfactant may reduce the need of intubation in the first 3 days of life compared with CPAP alone in infants born at 29 to 33 weeks of gestation age with mild RDS, not the severe ones. Having said that, we cannot go ahead and give the recommendation for nebulized surfactant as such. So what does the European Consensus Guideline says on management of respiratory distress syndrome in 2019 update? It says that babies with RDS should be given natural surfactant. A policy of early rescue surfactant should be given as a standard, but there are occasions when you need to give surfactant in the delivery room suits, such as those babies whom you have already intubated for stabilizations. Babies with RDS should be given rescue surfactant early in the course of the disease, and a suggested protocol would be to treat the babies who are worsening with FiO2 requiring more than 30% on CPAP of 6. It says that you should give poractant, and the dose should be 200 mg per kg, the first dose. And the rescue dose should be the one which should be given. LISA would be a preferred mode of surfactant administration for spontaneously breathing babies on CPAP, provided that clinicians are experienced with this technique. And second, and sometimes a third dose of surfactant should be administered if we see that there is an ongoing RDS, such as persistent oxygen requirement and need for mechanical ventilation. So what do we have in future? The future is new generation of synthetic surfactant, which may be a standardized product, which has increased resistance to inactivation. And this was a first human clinical study of new SPB and SPC enriched synthetic surfactant, CHF 5633 in preterm babies with RDS. And they found that it was well tolerated and promising clinical efficacy profile. So we need to have more RCTs to recommend it. And then another thing which came up was intratracheal administration of budesonide with surfactant to prevent BPD. And there was a study which looked into this, which we gave surfactant 100 mg per kg and budesonide 0.25 mg per kg as compared to only 100 mg per kg of surfactant. And they found that BPD or death was less with the combined group as compared to only surfactant group, 42% versus 66. BPD was less, 29% versus 50, and death was less, 13 versus 16%. So they concluded that this new therapeutic regime reduces the incidence of BPD and BPD or death. Some of the units are using, we are not using at the moment. And then there are non-RDS uses of surfactant like meconium aspiration syndrome, congenital pneumonia, pulmonary hemorrhage, BPD, broncho, if it is very severe, CDH, ARDS, and bronchiolitis. When should you use surfactant in meconium aspiration syndrome? Only when there is a severe meconium aspiration syndrome, baby who is on ventilator, high requirement. Because when you give that to these babies, there is a decreased mortality rate. It shortens the hospitalization days. It reduces the severity of respiratory illness. However, we need to have more RCTs to prove the efficacy for a less severe one. So don't give to all the meconium aspiration syndrome. So to conclude, it's the first drug that developed only and only for the neonates. It was a major breakthrough in the neonatal medicine over the past 30 years. Reduces both neonatal mortality in RDS and yearly by approximately 50%. No increase in pulmonary or neurodevelopmental problems at long-term follow-ups. Highly cost-effective therapy, and further potential applications are currently under the investigations. So if we look at the management of RDS, it definitely CPAP helped, closure of the PDA helped, but when we put the surfactant in, it really brought down the RDS and improved oxygen therapy, ventilation, and respiratory management. So successful warrior is the average man, and with laser-like focus, Bruce Lee, I would say. Past, present, and future. So the past is first-line CPAP, very less. ET prophylactic surfactant was too much in use. ET rescue surfactant was also useful. Present is much more use of first-line CPAP, very, very less or no use of ET prophylactic surfactant, and ET rescue surfactant is in good use. Future could be CPAP, nebulized surfactant, LISA, and very less use of ET rescue surfactant. Thank you very much. Open for questions.